Thank you very much. Presentation. Can I just deal with the issue about numbers? I'm just a little concerned when you were saying, you know, there's anything up to 10,000 people, women that may have had mesh used and that procedure followed, and yet we've only just slightly over 100 people have attended specialist clinics. And, you know, we've heard earlier this morning that there is a concern with a large number of women who've gone through the procedure and feel that they haven't received the required follow-up care. And do you not think that there is obviously something missing? You know, you referred yourself to 190 people making initial contact. You're saying there's various figures about 10% have adverse outcomes as a result of the procedure. So if 10% of 10,000 is 1,000 people, yet only 100 people have attended the clinics. Almost 200 make contact, but what I think you can infer is that a number of other people would have been seen at general gynecology clinics, you know, in the last number of years. So the complications people can have after mesh can vary from, you know, more minor to more serious. So I would expect that those who made contact were actually those at the most serious end of the scale. So, for example, somebody might have voiding dysfunction or difficulty in passing urine after a tape was put in, and that might occur in the first 2 or 3 weeks after surgery. That would be addressed by the clinician, and the woman may not have any complications going forward. We wouldn't have captured those types of instances. So I suppose there are so many different gynecology clinics where women would have been seen and, you know, potentially had any issues addressed. Okay, yeah. And just in relation to where, say, people are looking to get treatment abroad because they're not happy with the service here in Ireland, do you accept that there may be a scenario where people have been received and have been reviewed in Cork and in Dublin and are not happy with the outcome, that there's a need for a better approach on this, in that people feel that they're then going off and trying to get assistance from elsewhere without any support from the health service here? I would say I don't think it's any clinician wishes to put barriers, you know, in front of women. Like, I've dealt with women in different, or patients in different spheres where we've engaged with the treatment abroad scheme for, in other conditions. So that has been part and parcel of the health service, and, you know, people have a professional obligation to engage. You know, the treatment abroad scheme is not just for this area; it's for other areas. And I don't see that clinicians... for instance, I came across a scenario, nothing to do with gynecology or obstetrics, where a consultant here refused point blank to allow the person to get treatment in a particular area. And the person went, the consultant was requiring him to go through an operation where in fact he could get treatment abroad where he didn't require an operation. And there was a standoff between the patient and the consultant. The patient did go abroad, got the treatment, and then there was a scenario where I was involved in a legal capacity in trying to recover the money from the insurance company, which we eventually recovered through a legal process. So what I'm saying to you is that there is a difference of opinion sometimes with consultants, and that maybe the best outcome for the patient is to get that care abroad, because that's the belief they have. Well, I mean, the reason that there's two centres is so there is recourse to more than one consultant, and you know, that's fair to say. So as much as possible, you know, we would feel that people should be able to, and doing our best to provide care in the country, conscious of, you know, travelling abroad is not an easy option for anybody. So I think none of this is going to hinge on one consultant or one consultant's opinion. But do you not accept that there are times that there are people who believe, you know, no matter what advice they provide here in Ireland, because of what has happened to them, there's a lack of trust with the system here. And sometimes it might be a better option to allow that person to exercise and I'm not talking about going, obviously I'm talking about staying within the European Union, because the cross-border healthcare directive provides for that. And so they have to stay within a country within the European Union. But do you not accept
that there might be a process put in place to accommodate that person who believes that they've lost the trust in the system here.
I just might like Catherine to come in on that.
Deputy Burke, you're absolutely correct, and we come across that situation, I won't say often, but certainly regularly, and that is probably the biggest advantage to the cross-border directive, because the patient doesn't require a consultant to sign off on a referral like the treatment abroad scheme does. So, and you're correct in what you say about the cross-border directive. It refers to the EU and DEA. So if a patient has a GP referral, they can use that referral to access healthcare under the cross-border directive. They don't require prior authorisation or prior notification. They can simply, with their properly executed GP referral, opt to access healthcare in another country in the EU or EEA.
And just on that, you're talking about access within the EU. Does that now exclude access to treatment in the UK now because of the UK?
It excludes access to the UK and Switzerland because neither of those countries have transposed that.
Whereas previously they would have been able to go to the UK.
But the Northern Ireland Planned Healthcare Scheme was put in place by the Department of Health, and that's been continuing on an administrative basis, and you can access healthcare in Northern Ireland in the very same way as the cross-border directive in the private sector.
Okay, but you're saying so that where someone has lost total trust in the system here, and this is not a criticism of the medical professionals, and you know it happens in in all areas, whether it is on the legal world, in the medical world, it happens in every sphere of Irish life. But you're saying so that if a GP is satisfied that this person does require an opinion and maybe treatment, that there is nothing preventing a GP from giving a referral letter for that person to travel. Now, the disadvantage, of course, is the treatment abroad scheme is that the person has to pay in advance and then try and recoup that afterwards.
Yeah, you're absolutely correct. So that is the big disadvantage of the
So it's not open.
directive.
It's not a scheme that's open to everyone.
Cross-border directive is open to everybody.
Well, I know, but because of the cost issue, it's not open.
Look, financial can be a barrier, but I can tell you we're doing all we can. I'm actually meeting with the Irish League of Credit Unions this afternoon to try and put in place a scheme to allow patients to have access to funding, because it is the patients who don't have private health insurance that are using the cross-border directive. So it's very important that they have access to financing.
Yeah. Sorry, could I come back to Dr. Murphy, and that's in relation to the number of consultants who would have been providing this care is quite small in real terms. My understanding is that it may be as low as under 20. Therefore, the collection of data, therefore, should be, I know it's not easy and you have to go through records, and because we have this crazy system here where we don't have an up-to-date data collection service in real terms. Our medical records are still paper files. But is it still not possible to collect that data because of the small number of consultants who are providing this type of care?
Potentially, individual consultants can, and some of them have gone through, obviously, their own files and that. And some of the difficulty can be, obviously, people have retired, and also it's spread not just in, maternity units with gynecology, but also some standalone gynecology units within HSE hospitals and then private centres. So there's, it does cover in a large number of units, and some of them have better data collecting systems than others, all right, for sure. But as an aim, I accept that it would be great to get more granular data, for sure, to know, exactly what the number is, and potentially have a better denominator as to, we would know how many people actually had good outcomes as well as poor outcomes.
And can I just ask, in relation to the pausing of a particular medical procedure, this was paused in 2018. If a medical procedure is identified at some stage, no matter what area of medicine, how long does it take us really to take action to make sure that we act on what is international best practice about pausing a particular type of treatment? Is there a mechanism in place for doing that?
Yeah, I might come in on that if that's okay, Deputy Burke, as well, and I'll bring Clean in afterwards. That can vary and depend on the type of notification we receive. So it could be through HIPAA around the use of a particular implant or product that we use in terms of an intervention with a patient. So that can be immediate, where they notify a pause to us and say, please don't use this product. Or it can vary into emerging evidence depending on the use of that product and the type of complications that result, and that can happen over time, so that can have an impact. So it depends, but I might bring Clean in on.
Yeah, and I think in the CMO's report it wasn't envisaged as being as long as it has been, and obviously lots of things have happened in the health service in the last 2 years, you know, that have impacted on that. So there may well be changes in other jurisdictions that also impact on us, but yeah, it wouldn't normally have been as long as that, if you like, if that's the answer to your question.
But I mean, what are the indicators that need to be in place before we decide to pause a medical procedure? Is it at European level? Is it at UK level? Is it at level in the US?
Well, often it is, you know, in Ireland it's often we would respond to, for example, signals in the UK. We had examples of that in vaccination, where there was a pause in a particular vaccine until more evidence was available, and then the pause was lifted. So we often do follow trends in the UK, our nearest neighbour, and there would be obviously close communication between clinicians and CMOs in both Ireland, Scotland. So there's close communication in those matters.
Thank you very much. Thank you, Chair.